Hey guys, welcome back to DOCSHAALA. So in our next video of case-based scenario, we are going to see about herpetic gingivostomatitis from the topic Pedodontics. Okay. So the introduction, when we are coming to herpetic gingivostomatitis, we are clear that it is from HSV virus, that is herpes simplex virus. So it is a manifestation of herpes simplex virus 1, type 1. Okay, so it is characterized by high grade fever and painful oral lesions. So its main characteristic is high grade fever along with painful oral lesions. So it most commonly occurs in children from 6 months to 5 years. So it most commonly occurs in children with from 6 months to 5 years. It can also occur in adults. So it usually spreads from direct contact or via droplets of oral secretions or lesions from an asymptomatic or a symptomatic individuals. Okay, so once a patient is infected with this, what happens? The infection can recur in the form of herpes labialis, that is cold sores. Okay, cold sores around the mouth. So with intermittent reactivation which occurs throughout the life. Okay, so once he's infected during his childhood, it can recur and recur and recur even in his adulthood and even throughout the life. Okay, so let's come to pathophysiology of the disease. So both HSV1 and HSV2, that is, we have two types of herpes simplex virus, right? HSV1 and HSV2. So these both have three biological properties. So there are three main biological properties. So they are, first one is neovirulence, latency, and reactivation. Okay, what is neovirulence? Neovirulence is the ability to invade and replicate in the nervous system. That is, they affect nervous system directly. Okay, they have the ability and to invade and replicate inside our nervous system. Then latency. Latency is the ability to maintain the latent infection in the nerve cell. So they have the ability to maintain that nervous infection in the nerve cell. Okay, the latent infection in the nerve cell. So that is why it recurs and recurs throughout the life. Okay, then reactivation. Reactivation is the ability to replicate and cause the disease process again. Okay, once induced by specific stimuli, but it has to have some specific stimuli to get recurrent. Okay, so HSV1 commonly causes herpetic gingivostomatitis, that is, it affects the gingiva, and eventually labialis using the same biological properties. It affects the gingiva when the patient is in child, but later it affects in the form of labialis throughout his entire life. Okay. Then coming to pathophysiology, this is just a small video of lytic cycle of viral replication. So I think you have already seen it in our uh, uh, videos, right? So this is just attachment entry. So it enters into the cell, it gets replicated, assembled, and then releases its particles. So this one is a very popular video of our Instagram. So I've just pasted it here so that you'll know. Okay. Then coming to the pathogenesis of herpetic gingivostomatitis. So the replication of the virus happens, then the cell lysis and eventual destruction of mucosal tissue. So that is what I have shown you in the video before. Okay, exposure to HSV1 of the upgraded surface allows the virus to enter and rapidly replicate in the epidermal and the dermal cells. So clinical manifestation involves perioral blisters, erosions of lips and mucosa, and eventual hemorrhagic crusting. Okay, sufficient viral inoculation and replication allow the virus to enter sensory and the autonomic ganglia. So autonomic ganglia, that is, it is involving nervous system, right? So sufficient inoculation and replication allows it to enter into the sensory and the autonomic ganglia, where it travels intraaxonally to the ganglionic nerve bodies. Okay, then HSV1 most commonly infects the trigeminal ganglia. It most commonly infects the trigeminal ganglia, where it remains latent until reactivation, most commonly in the form of herpes labialis. Okay. So histopathology. So you can observe the histopathology of the HSV here. So there is degeneration of the stratified epithelial squamous epithelial cells, so that you can just appreciate here. There is degeneration of the cells, and also there is acantholysis. That is, they do not attach to the epidermis. Okay. And formation of an inflammatory filtrate around the capillaries of the dermis. So when we are seeing here in the uh, closer picture, there we can see the infiltrate around the capillaries, right? So this is called as, these inclusion intranucleary inclusion bodies are called as Cowdry type A, which are found in the light microscopy, showing arrays of viral capsids and electron dense glycoproteins. So these are the Cowdry type A type of inclusion lesions that we can appreciate under light microscopy. Okay. Then coming to the clinical features. So coming to the clinical features, the clinical features involve, so usually occurs in children. We have seen is, so they are not exposed previously to the infection and may be asymptomatic, but it develops fever, anorexia, irritability, and development of painful oral lesions. Then associated symptoms include malaise, lethargy, cervical or submandibular lymphadenopathy. Then initial sign involves hyperemia of the oral and perioral mucosa. Hyperemia means increased temperature, followed by rapidly spreading vesicular lesions on gingiva, palate, and buccal and labial mucosa. Okay, gingiva, palate, and buccal and labial mucosa. So how the lesions look? They ulcerate and then eventually rupture and appear as flat, yellowish in color, approximately 2 to 5 mm in size. Okay, and they are quick to bleed and typically heal without scarring in 2 to 3 weeks. So this is a very common lesion that we see. Okay. Then recurrent lesions develop in 1/3 of the patients. So the patient's symptoms include burning and itching, followed by formation of vesicular lesions in a localized area. The lesions may develop on keratinized skin, such as vermilion borders of the lips, perioral skin, or the hard palate. Okay, lesions may develop in when the patient is under physical or emotional stress or systemic illness. So sometimes we even see this in certain patients, even in our friends also. So other triggers include sunlight exposure and trauma during exams, right? So lesions occur in the same area during every episode of recurrence, and systemic manifestations such as malaise and lymphadenopathy are very mild. So this is how the lesion looks. So you can appreciate the lesion over the tongue, palate, right, in the lip, right. Then this is the perioral lesions. So they are appearing as crust in the perioral lesions, but they appear as a gray, yellow-gray lesions in the mucosa of intraorally. Then the management. So mild and self-limited condition this is. So supportive care is generally adequate for this. So for lips, you can use some creams such as petroleum jelly. And most important component in the management is hydration. We advise them to take more and more of water. So it is achieved with, if at all it is painful, we can give them analgesics, just the containing oral acetaminophen and some oral rinses like any rinses we can give. So to make more comfortable and promote fluid intake. Okay, so this is how we manage these lesions. So coming to a clinical scenario. So a 12-year-old girl complains of sore mouth. She has painful cervical lymphadenitis and a temperature of 39 degrees Celsius. Oral examination shows numerous yellow-gray lesions. What is the most likely diagnosis? So actually it is a 12-year-old girl. So Typically, what we have seen is 6 months to 5 years, but it can occur in any ages. So it's not a typical barrier. So cervical lymphadenitis is present. So temperature is high. Oral shows yellow gray lesions. So most likely diagnosis will be most probably. So we can just arrive to a simple diagnosis. We do not go for the remaining because they also have other conditions also associated with them. So the simple thing we can go is with the herpetic gingivostomatitis. Okay. If you like our video, do subscribe to our channel, and you can also follow us on Instagram handles at DOCSHAALA for dental content and at DOCSHAALA medical for medical content. You can also follow us on our Telegram handle. Thank you and see you again in the next session.